So, namaste and a very good evening, everyone. On behalf of Walter Bushnell Healthcare Foundation, I extend a warm welcome to all our distinguished guests to this special evening. As you're aware, every year we organize a scientific symposium to address the key issues in the field of Obs and Gynae, along with the IOG Dr. Stya Paul Awards and Oration Lecture, which is attended by a galaxy of esteemed national and international faculty. So once again, prior to the 12th IOG Dr. Stya Paul Awards and Oration Lecture this year, I'm delighted to welcome you all to one of its kind symposia consisting of 3 scientific sessions with leading national and international luminaries on the most happening topics in the field of Obs and Gynae. I'd like to inform you all that the entire proceedings of today's scientific session are being broadcast live globally. In fact, many of our well-wishers, both from India and abroad, have already logged in to watch this session, and a hearty welcome to all of them as well. I'd like to extend a special welcome to Mrs. Sushma Paul Barlia, a distinguished entrepreneur, industrialist, and educationist. Mrs. Sushma Paul Barlia is Chairman, APJ Satya and Swaran Group, Chancellor, APJ Satya University, and Chairman, APJ Education, which runs 26 institutions across India. She was the first woman to head a multi-state Apex Chamber of Commerce in India and the first woman in India to lead a pharmaceutical company of the group when not yet 30. She served on boards of IIT Roorkee and NIT Jalandhar, represented India on global platforms and stands committed to inclusion, women's empowerment, and value-driven leadership. Over the years, she has won numerous accolades, including Lifetime Achievement Award by SEPC, Ministry of Commerce and Industry, in 2024, and by Times Now in 2025. An innovator, she has several patents to her name. A hearty welcome to you, ma'am. I now would also like to specially welcome Mr. Nishant Barlia, grandson of Dr. Stya Paul, and son of Mrs. Sushma Paul Barlia and Mr. Vijay Barlia. He's the co-owner and director, Family Business Board, APJ Satya and Swaran Group, lead pharmaceutical vertical, office bearer, APJ Education, and pro-chancellor, APJ Satya University. He is an alumnus of Stanford University, USA, and Harvard Business School, USA, from where he has studied business management. Welcome, sir. Special welcome also for Dr. Neha Barlia, granddaughter of Dr. Stya Paul and daughter of Mrs. Sushma Paul Barlia and Mr. Vijay Barlia. She is the co-owner and director, Family Business Board, APJ Satya and Swaran Group, lead education vertical, office bearer, APJ Education and pro-chancellor, APJ Satya University. She is a graduate in economics from Stanford University in the US and holds a PhD in finance and master's degree in management and banking from the prestigious University of St. Gallen in Switzerland. She has graduated from the Owner's President Management Program at Harvard Business School. Welcome, ma'am. And now let us extend a very warm welcome to Dr. Deirdre Lyle. She is the Dunleavy Endowed Professor of Maternal Fetal Medicine at Stanford Medicine. She serves as chair and principal investigator of the California Maternal Quality Care Collaborative. Dr. Lyle brings more than 25 years of clinical, research, leadership, and teaching experience in maternal fetal medicine and has come all the way from US to join us. She is the esteemed speaker for the 12th Oration Lecture, Placental Dysfunction from Pathophysiology to Clinical Practice, of the IOG Dr. Stya Paul Award function, which is being held tomorrow at the same venue at 10:15 a.m. I also welcome Miss Miriam Lyle, her sister, who's accompanying her. So welcome. Dr. Deirdre Lyle and Mrs. Miriam Lyle. And now I would request Mr. Nishant Balia to come to the podium to present a brief introduction of Walter Bushnell and Walter Bushnell Healthcare Foundation. Mr. Nishant Balia, please.
First of all, a very good evening to everyone. Dr. Deirdre Lyle, Madam Berlia, distinguished ladies and gentlemen, it is an absolute delight to welcome you to this August gathering. I must say this gathering is really a testament to the bonds we have built over so many years, if not decades. We're deeply grateful for the opportunity to connect with you as old friends, colleagues, and trusted associates. And your support and active participation over the years has made this event truly special. I think it's one of the really few events, not across all medical professions, that we're able to now do. And we look forward to only, with your support, growing this tradition going forward. Walter Bushnell, as you know, has experienced remarkable growth over the past several decades, and particularly the last few years. So I thought it would be a good moment to give you a bit of an update of where we are and how things are going. We are, and another old friend, doctor, last year reminded me, we're a 100-year-old young company in India. We are now, and we've really been one of, as you know, one of the most established focus on innovative therapies, and we've really had a large focus on innovative medicine and evidence-based medicine over the years. And really our focus has been building through R&D, building through alliances, trying to bring more and more new innovative therapies into the country. We are now 32nd ranked by prescription out there, and I think one of the rare things we've done is very, very select number of brands. And I think that's very important because that's only really where you're able to bring the quality focus and the R&D focus and the scientific approach when you're focused in a few particular areas. We're one of the fastest growing companies in the country for many years now, and with, as per various market studies which are done regularly. And of course, we have many marquee brands, Dotin, Urospas, Venismin, Uralizer, Martyrdom, Folipure, Vartivity, all known names as such, of course, to you. But I think what I'm very, very proud about is that we've done this truly with science-led medicine. In our internal conversations with you, whenever we bring any recommendations, any references, any claims, we have a very strong focus on grades of evidence. We do a lot of clinical trials, including double-blind RCTs, and not only phase 3 studies, but importantly, phase 4 studies, post-approval studies. We've done almost around 17 plus studies, which have been, 30 plus studies, which have been published in major international journals. And I think that's the way so when we look after a molecule or we go after a brand or product, we truly understand, we go very deeply into it. And then we try to build a scientific base over many years, over a period of time, because we believe when we come to you, we should have that scientific backup so that the faith that you're placing in us, we are able to reciprocate it in a particular way. We do extensive pharmacovigilance. Every colleague of ours goes through pharmacovigilance training, whoever joins the organization. I think in many ways, particularly in the domestic market, we're well ahead. And the reason is we understand what it means when a patient has an adverse event and making the difference between an adverse drug event and adverse drug reaction. That's very important actually to make that nuance per se. And also I think the type of databases we have built. We have extensive digital cloud-based reference libraries. In fact, I know many of you, if you ever have a question, not only on our molecule, but any field in the therapy areas, we're able to reference data very, very quickly. And these are strengths that we built as such to bring that type of scientific medicine per se. On quality, we have various drug components of ours manufactured in facilities which are either US, EU, WHMP, Schedule M approved. Especially, I'm very proud of our hormones business. In fact, our largest market outside of India is now the US. And we're probably one of the largest exporters of estrogens, in fact, into the US now, among other areas as well. And I think we have had this dream of having a unified quality for all territories or jurisdictions. We've definitely already achieved that on the API side. We have a very large new facility coming up not too far from here in Roorkee. It's a capacity, 2.5 billion tablet capacity facility. To give a sense, the largest, I think, manufacturing dosage form facility for oral solids in the world is around 14 billion, which is in Northern Europe. And there's enough area for that to expand. And that's going to be a facility which goes live later on this year. And not only for US, Indian markets, we'll be targeting over 100 plus countries with that. And we have a very robust pipeline coming through. And so really we're going to have, no matter which markets you go in the world, the same quality system. And it's one of the very rare few countries, companies in our industry which are doing that as well. So you have that confidence when you prescribe that it has a type of system as such in place. Another part about us is that I think I'm aware of only 2 other companies who have, in the top 100 companies, which have this model of having our own branches, own depots in every state, which meet over 2,000 stockists and 500,000 chemists, and covering over 5,000 towns and city clusters. I think this is extremely important because when it comes to availability, ultimately, when you prescribe, you honor prescription, you expect it to be fulfilled. And more importantly, even while a drug says the shelf life on top of it, the reality is the shelf life is only maintained as well good as conditions are met. Typically, what happens in the retailers level, they keep stocks only for a few weeks at most. So it's really the depots that you have where GDP is practiced. So as you know, there's been a huge push on good manufacturing practices in our country, but GDP is still an area where there's a long way to go. And is that supply chain assurance, not only the availability, but quality? I think that makes a big difference to you, hopefully, when you trust your brands per se. A very unique part of what we do is a clinical resource center. In fact, I've heard from many colleagues in industry as well. It's one of the rarest things which are done in our country, where we are able to, because we realized one thing, hopefully, that the most precious thing for you is time. You as practitioners, you need every moment you have extra with your patients count, and we know the value of that. And so when it comes to medical information, publication support, statistical analysis, clinical case discussions, our team at our CRC is available for you. It is staffed by some of the leading academic doctors, some of you who are here. They have large teams also support any queries you have, support areas you have. And I'm very happy to know many clinicians across the country use us for the support. And I think it's something really which has been a very good partnership model, helping practice protocols build as such in our country. I'm also very excited about innovations ecosystem. In fact, I think this has been a thrust area for us, which is now really beginning to pay dividends. We have over 20 plus patented assets. Those are 20 different drug assets, which are our own patents. 2 are now in advanced clinical trials. In fact, they're positive readouts this year. And I think some of you may be aware there's been a huge shift in how R&D pipelines are taking place globally, where it used to be a story that Asia was where cost was an advantage, but now innovation is happening here. And innovation is happening here because clinical trial costs are much lower in our country compared to other places. And the protocols, scientific leadership, which many of you are providing here, what we call has now taken that to fruition. We started this journey, frankly, with one molecule. Now, before we know it, we've grown that pipeline to a very large extent. We have patents for each of these molecules in 30 plus countries. I think that's going to be hopefully a story that goes through over a period of time. And intriguingly, as we entered this world, we also got into a world where we started actually participating and working with biotechs all over the world. So I'm happy to share with you, there was one biotech company in San Diego. There was a very rough biotech financing market, by the way, after COVID, frankly speaking. They approached us with bridge equity financing. We provided equity finance. They recently, in December, achieved FDA approval. There's another company which in radiation therapy has another breakthrough therapy. In fact, now they've been picked up by the US Department of Defense, what we call for priority as well. We organize financing also for them. And so it's a very interesting world where the world has changed. One, somehow things have collapsed, maybe Zoom, maybe travel, maybe communication. But also I'm very proud to say that we are actually now beginning to push the frontiers of that. And I think we had a large focus not to just be a generics company looking at bringing a lower cost, but by building quality and building science. And today I really feel proud. I can say that we are participating in some of syndications, etc., and some of the absolute leading biotechs, what we call globally. And that's a role that we've started to play in a major way. And it's not only fortunately us, I think it's going to happen across our industry, but I'm glad to be that we are together at the frontier of that as our industry evolves in that particular direction. Of course, we have, and I should say that we now have 3 R&D centers. We have 2 at our manufacturing sites, and we have 1 in Sector 30 Gurgaon. And I'm very fond to say this because, well, it used to be that one of the major consultants, McKinsey, and we're good friends there, of course, they were right across us. So I used to always joke that McKinsey hires consultants, we hire scientists. So that was a nice joke I used to have, and I have some friends who've given me some feedback about that. But that's the attitude that we've had. In fact, if you ever visit our offices in Gurgaon, I think now there's been a fight for space. We built that space originally, and we've now 1 building is being built. Now we're planning to build a 2nd building, which is there. And over time, our R&D center started small, and now it's beginning to occupy more and more of our space. So if you come to a company, which I thought was very good from at least my academic days, that your lab size should be bigger than your office sizes. And that's exactly the area we're going through. And really some of the very pioneering work, whether it's in flow chemistry, whether it is in Sonos chemistry, whether it is in new approaches, high velocity approaches. We're also doing AI chem using AI for chem synthesis, for target screening, repurposing. Some of the really, and I would say some of the best minds in the country are also now with us. So if you do try to ever visit Sector 32, please do visit our facilities. It'll be a pleasure to have there. And if you have any wonderful ideas, we believe a lot of innovation can be done. Give us your problem set. We will try to find a solution for it. That's the way I would go about it today. I mean, that's really been what our focus has been. Of course, we are very proud of our engagement with our university. It's interdisciplinary center of excellence between the university. We're engaged and that's what the program is called through. And I think that's really been a mission that we've had, is that how do we bring knowledge, protocols, understanding of what best practices are across, and find places where we can have this dialogue. And this comes to the Walter Bushnell Healthcare Foundation. And I'm very glad and again grateful that you're all here and to support us and in this mission that we have to lead to better health outcomes in our country. So thank you very much for a very patient listening, and I look forward to engaging with many of you this evening and tomorrow. Thank you.
Thank you, sir, for that insightful introduction and for setting the tone for the evening. We now move on to the first scientific session of today's program, Premature Ovarian Insufficiency, Recent Updates. And to steer this important session, may I now invite the esteemed chairpersons of this session on stage. We begin with Dr. Deep. He is the director of Rajdeep Fertility Hospital and Research Center in Kota, Rajasthan. He is also the ex-president of the Kota OBGYN Society. Dr. Deep, to please join us. Welcome, sir. Next is Dr. Ritu Khanna, Director of Khanna Medical Center Fertility Clinic in Varanasi, specializing as a fertility specialist and endoscopic surgeon. Dr. Khanna is the National Vice President of Indian Fertility Society and the Secretary of Society of Fetal Medicine UP Chapter 2426. Welcome, ma'am. We'll be also joined on stage in a short while by Dr. Mahesh Gupta. He's one of the leading gynecologists of the country and is the director of Indus High Risk Pregnancy Hospital, Ahmedabad. He's a recipient of Foxy Star and Foxy Legend Award and has developed, patented, and published techniques to control PPH, which has been endorsed by RCOG. He also has the American patent of suture material used for PPH. He'll be joining us soon. I now invite Dr. J.B. Sharma, Editor-in-Chief of the IOG Journal and Head of Obs-Gynae at Yashoda Medicity, Indirapuram. He previously served as Professor and Unit Head at AIIMS, New Delhi, and specializes in key gynecological areas including urogynecology, genital tuberculosis, and medical disorders in pregnancy. Welcome, sir, Dr. J.B. Sharma. May I now invite on stage Dr. Cynthia Alexander, Senior Obs and Gynae with over 35 years of service in Tamil Nadu Medical Services. She was a former HOD, Madras Medical College and Stanley Medical College, former Director, Institute of Obs and Gynae, Chennai, and the recipient of Lifetime Achievement Award from many organizations like Times of India and Economic Times Award. Dr. Cynthia Alexander, welcome, ma'am. And joining us now on stage is Dr. Narendra Malhotra, an esteemed medical professional with an impressive array of accomplishments spanning decades of contributions to Obs, Gynae, and infertility treatments. He is the Managing Director of Ujala Cygnus Rainbow Hospital, ART Rainbow IVF, Agra. Dr. Narendra Malhotra, welcome, sir. And now I have the pleasure of introducing the speaker of this session, Dr. Ratnabali Chakravorty. Premature ovarian insufficiency. She'll be speaking on this topic. She's the director of MAGS Medical and Research Center Private Limited and IVF and Infertility Clinic MAGS. She's currently a consultant, Obstetrics and Gynecology, Manipal Hospital, ILS Hospital, Bhagirathi Neotia Women and Child Care Center, Kolkata, recipient of many prestigious awards. She received the IMA Excellence Award in 2025. Welcome, ma'am. Ma'am, kindly note that the total duration of the presentation will be 20 minutes, and the first buzzer would ring at 17 minutes and second at 19 minutes. I'd request you to please adhere to the timings, and I now request Dr. Ratnabali to begin her presentation.
Before Dr. Ratnabali starts, let's welcome everyone. And I just want to make a comment here. This 3 hours today from 6 to 9 is the most energy hours of India. 6 planets are on the line today. And it's a full energy hours for us. So congratulations to all of you. Make a wish, it'll come true this time.
Thank you, chairpersons, for a kind introduction. Namaskar and good evening to all the dignitaries and the audience present over here. Premature ovarian insufficiency is no more a fancy term mentioned in the textbook. Today, it has become a pressing problem for all the gynecologists as well as the physicians. However, as an Indian, I feel proud to tell you that this term, this premature ovarian insufficiency, which has been coined maybe some 20, 30 years back in the Western medicine, has been mentioned in our Vedanta long, long back. My presentation, please. So, 1500 years before Jesus came in this earth, in Atharva Veda, it was mentioned about the premature ovarian insufficiency, definitely in some other name, but it was recognized by our physicians. We are proud about that. And 1600 BCE, Shushruta Samhita, you know, our oldest medicine book from India, mentioned Rajaksha, which means the premature ovarian dysfunction. Talk about the Aristotle, it's 350 years back, and the International Menopause Society, which was established in 1978, found out the age of menopause, round about 50 to 52 years abroad, and Indian Menopause Society, which was established in 1996. We did some studies, some epidemiological studies in 2000s, and we came up with the data that natural menopause should happen in the Indian woman between 47 to 48 years. However, the problem rises because we find premature ovarian insufficiency is not a rare condition. In India itself, out of this 100 women, 3.7% will suffer from premature ovarian insufficiency, and early menopause, that is menopause between 40 to 44 years, will happen in 12.2%. If you think about the states of India, the highest incidence is in Andhra Pradesh, 14.6%, and lowest in Kerala, 1.1%. In West Bengal, where I hail from, it is 3.8%. Now, there are lots of causes from which we were talking about the causes idiopathic for a long years, but now we have come to know many of them are due to autoimmune diseases, which are very common nowadays, and the genetic causes, which I will discuss in detail. And look at the other causes, smoking. which has become so popular nowadays among the young women, and that causes, due to its lot of polycarbons, premature ovarian insufficiency. And we are blessed with lot of chemotherapies and radiotherapies and surgeries nowadays, which treats the cancer patients, but ultimately might lead to the premature ovarian insufficiency. Also, there are environmental toxins we are engulfing every day from air or food or water. That's causing premature ovarian insufficiency, and infections, of which tuberculosis is very common in India, and the cytomegalovirus infection, mumps, etc., causes the same problem. The genetic causes, which I'll discuss a bit more in details, while thinking so, we should know, does menopause occur in all mammals, all living beings? No. Among the mammals, if we look at the nearest kin of the human beings, the chimpanzees with 48 chromosomes, they don't suffer from menopause. The monkeys and others don't suffer from menopause. On the other hand, the whales, they have menopause. And you can see the whales, why they are suffering from menopause. It has been found that their brain is much more mature to understand that if they're younger whales, the young female whales, they conceive and they give birth to a new generation, those are much more healthy. They have much more better chromosome and genetic profile than that by the older ones. So now, after they suffer from menopause, they become leader of the pack. And while they pass in the winter season from the Arctic region to the southern part with a much warmer sea, they become the pathfinder. So can you just take into it, because it's not just dropping, yeah? Can you just look into it? Hello? Is anybody? So discussing about the whales, we should look at the chromosome number 2, which is the second longest chromosomes in the human beings, containing 8% of the genetic material. And this contains both the genetic materials for the soma as well as for the menopause. And it is shown very clearly that these gene, any changes in these gene, changes the timing of the normal menopause. So the trial reports and studies have come up from the medical centers in Netherlands, which shows very clearly that the genes that are responsible, actually there are DNA repair and maintenance of these chromosomes are mainly responsible for the age of menopause. And in any case, if it fails, then it is associated with the accelerated aging of the soma. And with this background in the mind, we should also know that our concept now must change. There is a paradigm shift from thinking that if menopause occurs, the woman ages. Rather, it is now if she ages early, then menopause takes place. So this is one of the paradigm shifts. Another I'll discuss later on. And all the chromosomes 12, 13, and 20, they are responsible for this antral follicle count, as well as the level of the anti-Mullerian hormones, and all the most significant single nucleotide polymorphism have been found in these chromosomes, which determine the age of menopause. Now you can look at the chromosome number 12, the changes over there. And these are the studies worldwide being done on the genome-wide association studies. A lot of women have been examined, and they had been found that these are clustered in the chromosome 5, 6, 19, and 20. And we are not going into details because we are not geneticists. However, to us, it's important, the clinical part. And the genes also, the estrogen receptor gene 1, estrogen receptor 2 gene, CYP, to name a lot of them are there. We are not going into details, but how they are affecting is by both the ways. One way, it's going via uterus, ovary, decreased ovarian follicles, less AMH and inhibin B, and loss of the menstrual cycle. On the other hand, it's acting via the brain, hypothalamus, desynchronized gonadotropin release, we get the hot flashes and loss of the menstrual cycles. And when we look at this, this is how the genes, ESR, that estrogen receptor gene 1, estrogen receptor 2, and others act via various pathways, acting on the FSH, acting on the 17-beta estradiol pathways to cause the early menopause. Also, if we look at these, there are two other genes which act in two other ways. One by the release of the growth hormones, which acts on the follicles, and other by preventing the apoptosis, cell death, and ultimately causing the early menopause. So with lot of other genes being involved, we are looking as the clinicians to the consequences. And the consequences, both the soma and the menopausal changes, decreased bone mineral density, increased cardiovascular risk, urogenital atrophy and sexual dysfunction, the mood disorders and cognitive decline due to its effect on the brain, ultimately leading to the impaired quality of life. And lot of other long-term consequences also take place, where there is the increased risk of the cardiac problems, the strokes, the heart attacks, metabolic problems, the dyslipidemia, the diabetes mellitus type 2, the osteopenia, osteoporosis, sarcopenia, psychological problems, dementia, life expectancy, not to talk of infertility, which I'll discuss later on. And if we look at these long-term consequences, what we should do, we have to have a comprehensive management. Not only we diagnose, but we have to tell the patient. This is most important, the counseling part. So in the history taking, we have to know whether she has got any increased chances of cardiovascular risk or osteoporosis and fractures. We have also to look at the brain portion, and we have to tell her about the lifestyle management, the psychological health, where she should go to a psychologist, to a psychiatrist, to a counselor. We should also look at the systemic hormone therapy. We should discuss whether it should be oral, whether it should be percutaneous. We should tell her about the bone health, the heart health, the brain health. The sexual function definitely will be jeopardized, and we should talk about that to her freely, and the genitourinary symptoms of menopause. So with all this comprehensive management, the hormone therapy remains the mainstay. And this is the difference between treating a menopausal woman and treating a premature ovarian insufficiency woman. This is a must, and we cannot deny a woman to replace estrogen hormone if she's suffering of POI. And that should be given till the age of 50 years, the natural age of menopause, whether she is suffering from estrogen deficiency or not. And this is for primary prevention, which is not in a normal natural menopausal case. And looking at this, we should also remember that there is no evidence of increased chances of breast cancer in this woman, which we should tell to the woman. And also we should say that yearly we will check you up. So with this background, we know that the woman, whenever we replace the hormone, it will take care of her vasomotor symptoms, genitourinary symptoms, cardiovascular problems will be taken care of, quality of life increase, and if she's too young, the puberty induction will be there. And when this hormone therapy is being instituted, what are the options? Earlier, we used to give the synthetic estrogens, which are much stronger but has got a lot of side effects. Then we started with the conjugated equine estrogens, and that also is not natural to human being. So later we found that is giving increased chances of cardiovascular problems, the strokes and breast cancers. So now we have switched on to the natural estrogens. A lot of natural estrogens, we are using valerate 17-beta estradiol, the natural estrogens, and progestogens, as the uterus is also there to protect the endometrium. And apart from giving medroxyprogesterone and non-etesterone, which are much more androgenic, we have now switched on to the micronized progesterone, norethindrone acetate, or in some cases, the intrauterine levonorgestrel device. So as we are giving her HRT, we have to counsel her properly. because she is the woman who has to continue with the treatment. She cannot stop it in between till the age of 50 years. So talk her about the natural estrogen. It is safe, and if you give it in a micronized form, where the surface area of each small molecules, of the small particles, are much more. They'll be absorbed more, bioavailability will be more, and they'll be very low dose, persisting throughout the day in her circulation. The liver metabolism will not be jeopardized, and GIT first pass effect will be there. So this is how the micronization is being done, and in order to improve the absorption, and estradiol is broken down into smaller particles, and they are being absorbed easily. So estradiol valerate giving in the micronized form along with the natural progesterone or norethindrone is now the drug of choice. However, for cost control, somebody prescribes the contraceptive pills. They are also giving very good result. However, for a long term cannot be given due to its synthetic nature, and hormone-free period cannot be given in that. Now it's very important to think about a lot of women will have comorbidities, what to do in those cases. So in Turner syndrome, as we discussed, it has to be given till the age of 50 years. If someone is treated for breast cancer, we cannot give estrogen. But if somebody has got breast cancer in the family, mother or anybody like that, and BRCA, she is BRCA1 or 2 positive, in that case also wheat is not a contraindication. We can give, if her prophylactic bilateral salpingo-oophorectomy has already been done. In that case also we can give her estrogen. In endometriosis, treated, operated, after salpingo-oophorectomy is done, we have to give estrogen along with progestogen so that there no reactivation of the disease. If she is suffering from migraine, estrogen being a contraindication, but in POI, we have to give estrogen, transdermal, low dose, and even if she has got aura, estrogen is not contraindicated that in case. Hypertension, obesity, we must be giving. There is no contraindication. Transdermal estradiol will be better in our case. Even in a venous thromboembolism, after discussion with the hematologist, we have to prescribe in a premature ovarian insufficiency the estrogens, which are contraindicated in other women. Cardiovascular disease, after consultation with the cardiologist, a low-dose transdermal estrogen can be given to this woman. And a woman with fibroid also, it's not at all a contraindication. We have to give estrogen with regular follow-up. So keeping this into mind, it has got a wide range of application, and all POI patients have to get it. What about the non-hormonal and complementary therapies which some of the menopausal women take? It cannot be given in the POI patients. They do not have any benefit out of it. There is no evidence out of it, and therefore it cannot replace the HTs, the hormone therapies. Some of the women, even with the oral systemic estrogen therapy, will get some genitourinary symptoms. In those cases, we have to give local estrogen therapy, some moisturizers and lubricants, hyaluronic acid based, and a broad progesterone, that is intravaginal DHA, is given. And they are also giving oral ospemifene, which is not available in India, but they are giving good results. Regarding the sexual function, we have to discuss in detail and clearly and tell her if she has got painful intercourse, she can use a 4% aqueous lidocaine jelly, she can use a local estrogens, and transdermal testosterone therapy for the hypoactive sexual disorder is very important, but giving testosterone for a longer period of time is not advocated for 3 to 6 months because the long-term safety is unknown in these cases. The source of presentation here is from the International Menopause Society white paper, which was produced by the President Nick Paney, who came to India during my presidentship in 2018. And after that, this white paper, we all of us contributed something over there, and it was established, and accordingly, we are treating them. Lastly, the fertility in POI. a few slides on that. We cannot deny a woman who has got POI coming to us asking for a child. What can we do? In autoimmune cases, in idiopathic cases, in toxin cases, sometimes if she's quit smoking, she can ovulate once or in a lifetime, and she can get a rare chance of pregnancy. But ideally, the oocyte donation or embryo donation with IVF-ICSI is the treatment of choice. However, stem cells are coming over here. Today's science, tomorrow's future. And now we can discuss, but I'm not going into details. Many a times in these cases, we find that the size of the uterus is small, and here we have to give estrogen. 2 milligram of estrogen valerate we give for almost 6 months of time, so that the musculature develops, the endometrium becomes thick, and the vasculature, which is very important for placentation and to prevent the recurrent pregnancy failure, we have to treat them with the estrogen before doing any IVF-ICSI. And also in these cases, PRP is given, the patient's platelet-rich plasma infusion in the uterine cavity. In our center, we are getting good result with it. And stem cells, the new therapy in infertility today's science, is to generate the new oocytes, and in the treatment of the Usher-Man syndrome is being done regularly nowadays. And we find that young woman in the premature insufficiency, there may be her own bone marrow stem cell can rejuvenate whatever eggs are left behind. And these are called the leftover eggs, the primordial oocytes. And if we give platelet-rich plasma directly injecting in the ovaries by laparoscopy or by vaginal route, that gives a very good result. And lastly, whoever the uterus is not congenial for any transfer, ectogenesis is coming up in 2016. 13 days size fetus is born, is made in the lab. Though due to ethical issues, we cannot talk about that, but maybe that is the future of the birth. In our center, we are doing a lot of genetic studies. We have come up with the 2 genes which are causing recurrent abortions, which are causing recurrent pregnancy failures, and genetic profiling is being done. We are looking at the POI patients. And in our country, all mothers are called Ma, whether she is really a mother, she is suffering from POI, has got menopause, but everybody is mother. And if you look at our Upanishads, there it is said, there is no shed like mother, no resort like a mother, no security like a mother, no other ever giving fountain of life.
देव्यै नमः ॐ अम्बिकायै नमः ॐ परमेश्वर्यै नमः ॐ ईश्वर्यै नमः ॐ अनीश्वर्यै नमः.
And in India, long back in the Rig Veda, it was mentioned that for the benefit of the human being, whether a male or a female, a mother or someone who is not being able to become mother, someone suffering from even POI, we should find out some way or other for which science is progressing. And in Rig Veda, it was mentioned, Charai Beti, Charai Beti. So keep moving, keep moving, keep moving until we can satisfy everybody. Thank you very much for your patient hearing.
ॐ विजयायै नमः.
A very nice presentation from spirituality to science to new advances. And I was thinking how we can prevent the POI by improving the and health of the female and reducing the use of the plastic, pesticide, infanticide, how we can improve our environment. So we should think how to prevent the POI. Treatment options are so many, and early diagnosis is always helpful to prevent the late complication.
Thank you, Ratnabali Madam, for that fantastic deliberation. And I think now incidence of this POI is really increasing in our practice. And of course, these surgery, whenever we do an IVF, say an embryo donation or an oocyte, it's really, really rewarding. But destiny and nature you can never overcome, because I remember one of my patients who just was a doctor and conceived spontaneously. So that 5 to 10% who have a sporadic ovulation really need to be taken care of. And sometimes we have these patients coming up with primary amenorrhea if the ovarian function ceases before puberty. And of course, they are lifelong friends, because if we really look after them, we're going to save her brain, her heart and bone, and of course, her longevity also. So thank you so much.
Thank you, ma'am, for a nice lecture. And as rightly said, madam, that now this paradigm shift regarding the menstruation, menarche as well as the premature ovarian failure. The menarche is also going little earlier, and as well as the ovarian failure is going also earlier. But when it comes to a treatment of ovarian failure, premature ovarian failure, particularly in perimenopausal and premenopausal women, we always think about the thromboembolism and the contraindications and the complications of giving this treatment. But when that patient's requiring the fertility treatment, the IVF specialist, this is a contradiction. Just I'm telling that when that patient goes to the IVF specialist, they are very free to give all estrogens and progesterone. So it is depending upon what the patient is needing and what the treatment is required. That's accordingly the treatment is to be given. Thank you again so much, and thank you, this Walter Bushnell people, for arranging this nice gathering. Thank you.
Yeah. Thank you, Dr. Ratnabali. That was a wonderful talk and mesmerizing talk on all aspects of premature ovarian insufficiency. What we should use rather than failure? It's more sympathetic to the woman. And we are seeing now cases. I've seen unmarried girls, 24-year, 26-year medical students, and like medical college students, and they become very much depressed. And also we have to raise, as Dr. Mahesh said, their morale, that there is nothing. We can give you hormonal therapy, and just like with womb donation, they can have conception also, and they can have normal lifespan. And Dr. Ratnabali beautifully highlighted that new research is coming up where we can use POP, stem cell therapy, and although they are still experimental, but definitely we have to consult them. We have to be more sympathetic to them, and we have to do lot more research on premature insufficiency, including chromosomal aspects. In AIMS, we were doing study, and lot of patients had some chromosomal anomalies we found in them. So thank you very much for that. Thank you.
Thank you. Thanking Madam Sushma and the officers of Walter Bushnell for this opportunity. I thank Dr. Ratnabali for this very educative talk. Apart from the educative talk, I found empathetic talk also. And with this, especially in March, as we are nearing Women's Day, I thought this talk was empowering women and educating them with compassion and communication. So it will go a long way if these talks are spread to other doctors also. Thank you very much for this opportunity.
So very nicely brought up points on especially genetics and understanding the chromosome 2 and 13 and all, which is very, very important for all of us to be genetically educated now, because genetics is now the buzzword. And if you don't know genetics, then previously gynecologists think genetic diseases, there's no treatment. But at least preventive and at least diagnostic and counseling is very important. And when we talk of fertility, now these POI patients may spontaneously ovulate and even get pregnant. So that has to be kept in mind. And then when we take them for IVF, instead of jumping straight to oocyte donations, we can try injecting PRP into the ovaries. And what we do for the endometrium is we do it subendometrially, not instill it in the, because if you instill in the cavity, it is going to come out. So hysteroscopically subendometrial and ultrasound guided into the ovary is a good idea. Of course, stem cells, autologous stem cells taken out at the same time in the OT from the iliac crest, washed and prepared, because we're not allowed to process the stem cells and use. And now in India, we're also getting commercial exosomes available. But these commercial exosomes are not by Korean company, not authorized for used only for surface. So they're being used for aesthetic gynecology a lot. But there is a study which has recently been cleared by ICMR, and I'm a part of it with Dr. Prabhu Mishra, that exosome preparation machines and prepare them yourself in the OT, and then you are allowed to inject them into the ovary. So we'll be starting this study in January or maybe a couple of months from now. The protocols are approved by ICMR, and whoever is interested, I think we would love to have some participation from all over the country. And of course, by 2070, artificial wombs will be there. So it's already there, artificial wombs. A sheep has been reared till half of this thing, and human beings will be born from machines. So you'll be able to see your baby in a glass container and feed it and talk to it. That's coming. Thank you very much for inviting me and keeping this session, interesting session here. Thank you.
With that, we thank the distinguished panel for a very informative and engaging scientific session. May I request Mr. Nishant Barlia to kindly come on stage and present mementos to all of them as a token of our appreciation. Nishantji, I request you to kindly present the mementos. We begin with the speaker of this session, Dr. Ratnabali Chakravorty. Dr. Narendra Malhotra. Dr. Cynthia Alexander. Dr. J.B. Sharma. Dr. Mahesh Gupta. Dr. Ritu Khanna. And Dr. Desh Deepak. I request all of you to kindly step forward for a group photograph. Thank you all once again. And now we move on to the second scientific session of this evening, Recurrent Pregnancy Loss Current Concepts. I invite on stage the chairpersons of this session. We begin with Dr. Rajkumar Khubchandani ji. Dr. Rajkumar Khubchandani is practicing since 22 years at Ashirwad Maternity Home, Ahmedabad. He is ex-associate professor at High Risk Pregnancy Unit, Institute of Kidney Diseases and Research Center, Ahmedabad. Welcome, Dr. Rajkumar. The stage is being set up for the next scientific session, but let me save time. We'll also be joined by Dr. Rajendra Nagarkatti ji. He's still on his way. He's Obstetrics Gynae and IVF specialist at... Okay, he's here with us. Welcome, sir. He is Obstetrics Gynae and IVF specialist at Ashirwad Maternity and General Hospital, Mumbai. The president of Obstetrics Gynae Society, Meera Bhayandar. We'd like to welcome Dr. Rajendra Nagarkatti. Welcome, sir. Joining us also here is Dr. Amit Patki, Medical Director, Fertility Associates, Mumbai. He is also the consultant, Khar Hinduja and Surya Hospitals, Mumbai, and the immediate past president of ISAG. Welcome, sir. Next, I'd like to call on stage Dr. Rishma Dhillon Pai. Dr. Rishma Pai is a consultant gynecologist at Leelavati Jaslok, Sir H.N. Reliance Foundation Hospital and Hinduja Hospitals, Mumbai. She is the president-elect International Federation of Fertility Society. Let's welcome Dr. Rishma Dhillon Pai. Also joining us is Dr. Jaideep Malhotra, Managing Director of ART Rainbow IVF. She's credited with first 3,000 IVF babies of Nepal and the first IVF ICSI Tessa twins of Uttar Pradesh. She recently received the Legends of Foxy Award 2025. Dr. Jaideep Malhotra, welcome, ma'am. Dr. Pratap Kumar, he's a senior consultant at the Department of Reproductive Medicine and Surgery at Kasturba Medical College, Manipal, Academy of Higher Education. He is a member of the Project Review Group, PRG, on Reproductive and Child Health, Indian Council of Medical Research, New Delhi. Welcome, sir. And now I welcome on stage the speaker of this session, Dr. Nayana Patel. The speaker of the session will speak on the topic Recurrent Pregnancy Loss, Current Concepts. Dr. Nayana Patel is Medical Director of Akanksha Hospital and Research Institute, Anand and Zivia IVF. She is a pioneer in the field of IVF and surrogacy in India. She and her team have successfully delivered 1,737 surrogate babies at her center. Dr. Nayana Patel. I now request Dr. Patel to begin her presentation and kindly adhere to the timing, ma'am. Thank you.
Good evening, everyone. Dignitaries on the dais. And as Madam Sushma Paul Walia said, the beautiful Walter Bushnell family. All of us are their family. Thanks for this opportunity and thanks for this wonderful topic, recurrent pregnancy loss, current concepts. Yes, equally or more frustrating than POI. Definition, we know 2 or more pregnancy loss, but the biochemical pregnancy, ectopic and molars are not considered. And ASHRAE guideline and American both now say that loss of 2 or more pregnancies affecting up to 15% of pregnancies and 1 to 2 couples, which is significant clinical challenge. Key risk factors, maternal age, even advanced paternal age, and with each miscarriage, the risk increases and the couples should receive tailored help. If we look at the causes, the most frustrating is 40 to 50% unexplained. Then comes the autoimmune, 20%, endocrine, followed by anatomic, genetic, and infections. Maternal age, yes, significant increase after the age of 35 due to the low oocyte quality and more aneuploid oocytes. And by the age of 40, you can see that 50% risk is there. Uterine factors 7 to 28%, septate, bicornuate, arcuate, and submucosal fibroids, polyps, 2D, 3D, even hysteroscopy and MRI. Genetic factors in the early pregnancy loss could be as high as 50 to 60% with trisomy, monosomy, polyploidy. And also sperm DNA fragmentation is now considered one of the reasons. Hormonal, we know hypohyperthyroidism, hyperprolactinemia, but polycystic luteal phase may be. Diabetes type 1 is also a contributing factor, and low AMH is also now considered when you cannot find any other cause. Severe infections, yes, and bacterial vaginosis for the late loss. Chronic endometritis increases RPL and microbiome imbalance has a possible risk. Thrombophilia, though not common in this part of the world, more in the Western world, but yes, congenital factor V prothrombin mutation, MTHFR, but antiphospholipid syndrome, APS, is one treatable cause. Vitamin D deficiency and insufficiency affects. And immune factors, because pregnancy requires maternal immune tolerance. HLA gene variations, we know the autoimmune disease, SLA, APS, thyroid antibodies have an increased risk, and Treg dysfunction, the regulatory dysfunction of the cells, is very important. There is no clear consensus on this. Some guidelines do recommend, some do not. The other lifestyle is smoking, alcohol, psychological stress, environmental and ethnic factors. So it is multifactorial and often unclear. The first thing the patient asks is, what is my chance to prevent this miscarriage and have a healthy baby? So the key predictors are maternal age, number of miscarriages, the type of RPL, early pregnancy loss versus late pregnancy loss, the number of miscarriages, and if she has any previous live birth. Also, the APS antibodies, ANA and protein S should be considered. We know that after 3 miscarriages, a girl as young as 25 has a risk of 42% miscarriage in the next pregnancy. Treatment, yes, acute is surgical, medical, expectant, but after that, the RPL requires a thorough evaluation and care to identify the cause, the risk factor, and then the treatment, which is challenging. We all know that after 2 RPL, product of conception should be analyzed for chromosomal microarray. If aneuploid, definitely karyotyping and PGTA. If euploid, we consider all other factors. Thyroid replacement and hyperthyroidism should be treated. Progesterone therapy, yes, we have to, there are approved progesterone, dydrogesterone, and 7-alpha hydroxy progesterone caproate, which can be used. The natural progesterone had poor bioavailability, but now with the micronization, the problem has been solved, and the natural micronized progesterone will modulate maternal immune response, suppress fetal immunoplacental inflammatory response, reduce the uterine activity, improve the uteroplacental circulation. The vaginal is very good because targeted, high concentration due to the first pass effect, minimal side effects, good patient compliance as self-administration. The PROMISE and PRISM trial definitely said that after 3 miscarriages, there is a difference in the live birth rate, 72 versus with placebo versus with progesterone versus 52 with placebo. And the guidelines, our own FOXY says that vaginal micronized progesterone 400 milligram BD daily till 20 weeks of pregnancy when 3 or more losses. But if I ask here, everybody has prescribed and are still prescribing progesterone because every pregnancy is important. We don't want to wait till it turns to RPL. If there are cramps, we always advise, and that has become a routine, also a fear of litigation. Dihydroprogesterone is a retroprogesterone with high bioavailability, high progesterone receptor affinity, and agonist activity, safe in 20-30 milligram dosage, and it is a selective oral progesterone receptor, effective at much lower doses than oral micronized, and the main metabolite has the same activity. Immunomodulatory action of dihydrogesterone through direct indirect actions will reduce the pro-inflammatory cytokines, increase the anti-inflammatory cytokines, improve the subendometrial blood flow, and successful pregnancy. As early as 2015, a study showed that 10.5 miscarriage rate after this dihydrogesterone administration compared to control, which was 23.5, and 20 milligram can give 92% continuation of pregnancy and 90% patient safety. And the guidelines now, our FOXY says that can be considered in RPL and has been shown to be having the beneficial effect. This is a paper where I've combined vaginal micronized progesterone with oral dihydrogesterone, and it has shown increase in live birth rate and decrease in the miscarriage rate when combination is used. And this publication again has shown that dihydrogesterone may help threatened as well as recurrent pregnancy loss, and all these guidelines have endorsed it. Surgery, I do not believe that septum should not be removed. It can be removed, though guidelines say no proven, but at least fibroids, adhesions, and polyps have to be removed. Vitamin D supplementation we start. Genetic factors should be analyzed. Pre-implantation genetic testing, one of the major indication is recurrent pregnancy loss. A 25-year-old with 2 miscarriages, natural and IVF both, and previous failed treatments. Abnormal karyotype of the female. Immediately IVF, PGT, SR was done. Out of 6, only 2 normal, 1 transferred, and healthy baby delivered. At our center, we have biopsied more than 3,000 embryos so far from 2014, and RPL has been a major indication. Lymphocyte immunotherapy, it involves the injection either paternal or donor lymphocytes into the maternal body. And it has shown that it can improve live birth rates. But before doing that, because you are sensitizing the mother's body with that and foreign antigen which is coming through the sperm, we do the TNF alpha, give TNF alpha. If it's high, inhibitory drugs like tacrolimus or the pentoxifylline. NK cells, if it is high, though controversial, intralipids are given. ANA, if it's high, definitely HCQS should be given, 400 OD or 200 BD. Anti-TPO steroid should be given. And we do lymphocyte cross-match APCA. If it is not detected, lit therapy is given to promote immunotolerance to the fetal antigen and reduce the rejection and induce the production of blocking antibodies, balance the Treg cells and cytokine modulation. We start once before she plans a pregnancy. 6 weeks later, she is asked to plan. Once she is pregnant and there is heartbeat, we give the second dose of LIT, and at 12 weeks, the final. After that, it's not needed. A 46-year-old patient, 4 miscarriages, 1 due to round naturally conceived. AMH was good, 0.88. Failed IVF in the US, was advised donor egg. She comes to us. We do laparohysteroscopy, bone marrow-derived stem cells, ovarian instillation, rejuvenation. We also did the EVA, subendo PRP, and along with it, we did the lit therapy. She conceived naturally the next month itself and delivered a healthy baby in US. In IVIG, costly reactions are there, but still they are used empirically. Intralipid, when NK cells high, we can give it, but all under supervision. It will suppress the overactive immune response, reduce the cytotoxic NK cell, promote the immune tolerance, balance the cytokines, and that will help in trophoblast invasion and placental development. Corticosteroids, again controversial, but definitely beneficial in autoimmune unexplained high anti-TPO chronic endometritis. Prednisolone 10 milligram BD or dexamethasone 0.5 BD till 12 weeks of pregnancy. GCSF, still experimental. Thymosin alpha, the new kid on the block for boosting the immunity, because it helps in shift from TH1 to TH2. When the embryo is implanting, it is pro-inflammatory, but immediately after that, the uterine environment should become anti-inflammatory, and it helps in that, but not tried much in the RPL patients. The role of KIR and HLA-C, killer immunoglobulin receptors. So here the female can be AA, AB, BB. AA is the worst. It is the, and it can be inhibitory activating type, the inhibitory type. And C1, 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 C2, C2, C2. C2, C2 is the worst. So if the embryo is C2, C2, and here the female is AA, there is a definitely 100% rejection. And here the lit therapy from the partner will also not work. A donor lit should be taken. This is the typical report that we get, and based on that, the treatment is recommended. Chronic endometritis, we do treat it. Mainly it is, though it is said no, but hysteroscopic evidence, and if there is a biopsy, 100% beneficial. Antibiotic therapy, mostly doxycycline, metronidazole group, and steroids are given for a long duration. We are also working on low AMH, when all other factors are ruled out, and we go into that 50% unexplained group. There are a number of papers now which say that low AMH can be linked to early pregnancy loss and idiopathic recurrent miscarriage. So this is up to 23. Now we have many more patients, almost about 70, where they had 2 or more miscarriages with low AMH. Age group C34 and 0.44 AMH. So in 13 patients, we did either PRP or bone marrow-derived stem cells to rejuvenate the ovaries. We had 4 delivered, 7 miscarriage, and out of that, again 3 got pregnant and delivered. So this patient had 2 miscarriages, naturally conceived. So she went for IVF. Her IVF failed with own eggs. She went for donor eggs. That also failed, and she came to us. We found her AMH was 0.88, and there was no other reason for miscarriage. So we just advised her that we do your ovarian rejuvenation with stem cell therapy. She had come for donor eggs. We convinced her for this, and she conceived naturally and has already delivered. Why should we forget the males? They also have a contributing role in RPL due to the DNA quality, semen quality, genetics, epigenetics, and lifestyle that they have. So now we know that men with RPL can have reduced sperm viability, increased DNA damage compared to fertile controls, and the reduced sperm function. DNA DFI test, that is we do, and DFI HDS test also we do. DFI is linked to infection, chronic illness, diabetes, etc. And HDS is the defective spermatogenesis. If DFI is high and HDS is normal, that is normal spermatogenesis, then consider TISA sperms. This is the typical report. If both are bad, you could do nothing except for the lab procedure and lifestyle changes. But if the DFI was high and HDS was low, then testicular sperms would be very helpful. Psychological impact. While I was sitting here, I got a message, a sanitary pad with a drop of blood on it, a picture that doctor, I have spotting today, what will happen? She is pregnant. This is the anxiety and apprehension of a RPL patient. They are every day, every minute, they are living with that fear that what will happen the next moment. So that strongly psychological support should be given, and more meditation, mindfulness program should be done. Let us look at the guidelines. Bromocriptine, yes, should be given. Vitamin D supplementation given. Multivitamin supplementations to be given, lymphocyte therapy not to be offered. And if we look, they have recommended parental karyotype, uterine cavity assessment, thyroid function, glucose, antiphospholipid, antibody testing. Rest is all not recommended as of now. And the pictorial summary, typically the green, and APA, where we give baby aspirin, 75, 88, or 150 with low molecular weight heparin, which could be 0.2 every day, 0.4 thrice a week, or 0.6 twice a week, depending on the patient profile. Thyroid supplementation, uterine anomalies to be corrected, but not evidence for septum. Genetic tests with genetic counselor and PGTA. Immunological tests, no specific treatment. Sperm DNA fragmentation, only lifestyle changes, and screen for thrombophilia, which we rarely do here. But there is a red signal for other immunological tests, metabolic or hormonal tests. Definitely lifestyle advice, tender loving care, and prophylactic vitamin D is given. RCOG guidelines says psychological care will cure 75% of your patient. Prognosis less favorable with older and higher. And tender loving care should be given, and mental health should be taken care of. Endometrial sketch not suggested for women with RPL. Again, the same aspirin, low molecular weight heparin, PGTA only in selected cases. Other things are not recommended. But to conclude, I'll say that this RPL is a very traumatic condition affecting physical and psychological health. The guidelines vary, but we have to help our patient in whichever way we can. Major factors are genetic, uterine, endocrine, autoimmune. Each patient should have a tailored therapy. Evidence for many of the therapies like IVIG, corticosteroids remains unclear. The challenging part is 50%, 75% couples have unexplained causes. Here, a supportive care, a prognostic tool. I think we should all develop our own prognostic tool by the success that we have based on the miscarriages, age, what is the patient profile, and offer and guidance and support to the patient accordingly. Finally, it all boils down to counseling, tender loving care, and psychological care for the patient and for the couple. For you, it may be one of the number of patients that you see RPL, but for that patient, she is the patient undergoing RPL. So whatever best we can offer, even when we are offering an experimental treatment, we have to tell the patient, this is experimental, maybe this can help, maybe this cannot help, and counsel regarding the side effects, if any, and the cost, and then only offer the treatment to the patient. Thank you so much.
Thank you very much. Please sit down. Nayana Patel, for your excellent, we know because she's been having a lot of experience in this recurrent pregnancy loss and many other field also. I think the experiments, what you showed just now, probably you'll need a whole day to explain to us. Well, I had a very interesting patient. He had 6 abortions, all from Europe, and they were saying there's no other reason at all to abort, but she aborted. But she was aborting by 35 days. All the time, 35 days she had a bleed and she lost it. I just thought out of the box. I said, she's a fertile woman. Why can't you all come to India? Let me just do the ovulation studies and tell you when to have intercourse. And then on day 21, 7 days after ovulation, I did the beta HCG. It was around 15, 20, that way, very low. I started heparin at that time, and the pregnancy continued, and she's got a baby now. This is out of the box thinking. No literature says that. Thank you so much once again.
Thank you, Nana. That was a really wonderful presentation. And I know a lot of algorithms and a lot of things which are going on. But what I really feel is that a thorough evaluation is something which is really, really required. And most of all of us don't focus on lifestyle modification, especially for the couple, both men and women together, because there are a lot of these factors which today are playing their role, and we most of the times over medicalize these pregnancies. And I feel that there are two important things which are very, very important. Support the pregnancy well with progesterone once it happens, but please evaluate and do the lifestyle modification in the preconception period, which is one of the crux now, which is not really focused on, and all of us don't concentrate on that. So I would really bat for that today. Thank you.
Thank you, Nayana, for covering such a massive topic in a short period of time. I think RPL is one of the most complex subjects a gynecologist is faced with, and you can see the multiple etiologies, and unfortunately, the guidelines say that almost no treatment is recommended. And it was really like sort of shocking and upsetting for us when the guidelines came out which said that do not remove septum, do not treat submucous myomas, do nothing, which almost all of us actually do not agree to in our practice. Similarly, things change. Like now, the latest ESHRE guidelines have come out recommending dydrogesterone. All these years, there was no role for progesterone. And now 2025 December guidelines of ESHRE say, especially for luteal support and early days, dydrogesterone is recommended with some precaution, but it is. So things change all the time, and I think all of us, so many years into practice, have our own sort of ways of tackling these patients. Immunological methods, again, very, very controversial, absolutely not recommended by guidelines. But as you saw, each one has a few cases they can quote where some immune therapy has helped. So I think this is one area where we have a long, long way to go before we really understand and know how to treat. Thank you, Nayana, for throwing some light on this difficult subject.
At the onset, I would like to thank the Berlia family and Walter Bushnell for consistently having such high quality talks and speakers. And thank you, Dr. Nayana, for once again giving a great exposition on RPL. I'm very glad that you brought out paternal causes, because that has been my theme for my year in ISAR as paternal aging, and how we need to treat that 130 kg man sitting next to this woman, because I think lifestyle means for both, as Dr. Jaideep very lightly said. I think pregnancy is love and war. So some amount of pro-inflammatory is necessary for the implantation. So I don't completely endorse to trying to suppress the immune system of the woman, because I think we need to think about what happens to her maybe 10, 20 years later when we have tried to play with the immune system. We all, in our quest of trying to get a pregnancy, we have to think of the mother and child and think of the long-term effects. And I completely believe that tender loving care should be one of the many arms that we look at this woman. And I'm sure JB has worked in RPL in UK, where repeated sonographies, just doing repeated sonographies as reassurance, played a major role in trying to get successful pregnancies. So thank you once again, Nayana, for bringing out fine nuances. But I think we as doctors have to take one step back before we implement the latest, trying to improve our success rates. Thank you.
At the outset, I would like to thank the Berlia family for and the Walter Bushnell team for inviting me here to be a part of this wonderful yearly program, which really brings out the best in academics. And with respect to recurrent pregnancy loss, I think one of the newer things that is emerging is the immunological factor. And we all know the immunological role, the immunomodulatory role of progesterone. And add to that, now the newer things are coming up, like the use of course, there is low molecular weight heparin, the use of intralipids, and now recently even thymosin alpha is being added to the armamentarium. So yes, as Dr. Amit said, we should not jump into it, but we need to investigate patient because each patient is different. Now there are tests which are available to look at the peripheral blood NK cell levels, as well as many other tests which can really indicate whether there is a immunological factor, and if so, then and then only we should be going ahead with these treatments. As of now, they are yet, let us say, in an experimental stage, but as all the panelists have said, in our eagerness to bring out a positive pregnancy, we try different things, and as long as it does not do harm, it is okay. That should be the first principle, and ultimately, I think, as everyone said, the tender loving care seems to be the best thing. Reassurance, reassurance, and reassurance. Thank you.
Good evening, everyone. Thank you, Nayana Madam, for the excellent presentation. Thank you, Walter Bushner people, for inviting me here. Since I have been long using micronized dydrogesterone, especially nowadays, for all of my recurrent pregnancy loss patients for excellent results. I strongly recommend that while choosing the brand, one should especially so kindly go for the quality product, which is result oriented and already very good nowadays. Thank you.
With that, we thank the eminent panel for a very insightful and informative academic session. Thank you so much. And I would once again request Nishant Barliaji to kindly come on stage and present mementos to the panel as a token of our appreciation. Dr. Nayana Patel. Dr. Pratap Kumar. Dr. Jaideep Malhotra. Dr. Rishma Pai. Dr. Amit Patki. Dr. Rajendra Nagarkatti. And Dr. Rajkumar Khoopchandani. May I request all of you to kindly step forward for a group photograph. There's a request from Dr. Patki for Dr. Lyle to join them on stage along with Sushma Barliaji, Madam. Thank you all once again. So the topic for the third scientific session is pleiotropic effects of vitamin D in women's health, focusing on the emerging evidence highlighting vitamin D's role across reproductive, metabolic, immune, and post-menopausal health. The sample packs of Martivit D3, vitamin D3 nanoshots and drops have been already included in the registration kits for your clinical experience and evaluation for integrating vitamin D optimization into routine clinical practices. And without any further ado, let's begin this session. I'd like to invite the chairpersons of this session. We begin with Dr. Shweta Mittal Gupta. Dr. Shweta is the co-director and unit head, Center of IVF and Human Reproduction, Sir Gangaram Hospital, New Delhi, recipient of Economic Times Award for Inspiring Obstetrician, Gynecologist, and IVF Specialist. Welcome, ma'am. I'd like to invite Dr. Kabiri Banerjee, who is the Medical Director, Advanced Fertility and Gynecology Center, New Delhi, recipient of IVF Icon Asia GCC IMA 2021, in addition to many other awards and accolades. Welcome, Dr. Banerjee. May we now have on stage Dr. Anshu Jindal, consultant IVF specialist, obstetrician and gynecologist at Jindal Hospital and Dr. Madhu Jindal Memorial Test Tube Baby Center. Her special interests are adolescent health, infertility, ultrasound, poor responders, and microsurgery. Dr. Anshu Jindal. May we please have on stage Dr. Ashok Kumar, Director, Professor, Department of Obs and Gynae, Atal Bihari Vajpayee Institute of Medical Sciences, and Dr. Ram Manohar Lohia Hospital, New Delhi. He is the Chairperson-elect ICOG 2026 and the Organizing Chairperson of the recently concluded AICOG 2026, New Delhi. Dr. Ashok Kumar, welcome, sir. I'd like to invite Dr. Rishikesh Pai on stage, please. He is the Medical Director, Bloom IVF, with multiple IVF centers spread across India. He is a past president of Federation of Obstetrics and Gynecological Societies of India, FOXY 2023, and he is a professor of reproductive medicine at D.Y. Patil University, Navi Mumbai. Dr. Rishikesh Pai. Welcome, sir. And now, last but not the least, the speaker of the session, Dr. Subhash Wangnoo. He is Senior Consultant Endocrinologist, Apollo Center for Obesity, Diabetes, and Endocrinology, Indraprasth Apollo Hospital, New Delhi. He established and started the Diplomat National Board course training in endocrinology at Indraprasth Apollo Hospital, 2008, and is the founder member of Delhi Diabetes Forum. Welcome, sir. I now request Dr. Subhash Wangnoo for his presentation. Thank you.
Thank you very much. And thank you, Walter Bushner, for having me here. And I'm really afraid to see the women power. And I'm the lone endocrinologist to start my talk. But nonetheless, the topic is very interesting, and all of you have used this molecule in your day-to-day practice. So these are some of the outlines. I'm starting with the introduction. What are the pleiotropic roles? What is the role in the reproductive, OBG, obstetric care, gynecology, menopause, the formulation revolution, and the simplified dosing, summary, and conclusion. Now, just a little bit of epidemiology. Vitamin D is the most important nutrient in our body. It's a prohormone, crucial for the systemic regulation, and primarily synthesized via the UVB radiation, 80 to 90%, or obtained through diet, fatty fish, or the fortified foods. And our country being mostly the vegetarians also, we get hardly any people taking fatty fish and fortified foods. Exists in the nature in two forms, D2, the ergocalciferol from the plants, and D3 from the animal sources and the skin synthesis. If you see the Indian paradox, despite being so much a sun-rich nation, we have almost 99% patient having vitamin D deficiency in our country. And this is not exaggeration. And I think sometimes I just studied the vitamin D in our medical profession in our hospital, the Apollo Hospital. I think almost all of them having the vitamin D deficiency or insufficiency. So this deficiency persists regardless of the socioeconomic status or geographic location. India is a heliophobic nation. We try to cover our body because we should not get the sunburns or your face should not get spoiled. And the cultural factors, the protective clothing, environmental barriers, high air pollutions, particularly in city like New Delhi, which blocks the UV radiation. Dietary habits predominantly, I said, the vegetarian diets lack natural vitamin D sources. Some of the numbers we have to remember that deficiencies when the vitamin D levels are less than 20 nanogram, insufficiency between 20 to 30, sufficiency more than 30, and optimal for the extraskeletal benefit is 40 to 60. We are fortunate enough that each and every lab in our city of Delhi is having the facility for the vitamin D assays. What is the classical role of vitamin D in the skeletal integrity? I recently published a booklet on vitamin D and the skeletal health, which is going to be released shortly. And the vitamin D basically promote the intestinal calcium and phosphate absorption, which is essential for the mineralization. And listen, deficiency leads to a 2 to 3% higher rate of osteoporosis in Indian women, critical for supporting peak bone mass during adolescence, which is the greatest factor of having your bone strength later on in your life. And defining the pleiotropic, what we are talking today, vitamin D receptors. We have to know about the vitamin D receptor, which is expressed in almost every tissue in the body, including the ovaries, uterus, and the placenta. And it regulates over more than 200 genes in cell proliferation and the immune function. Few decades back, we were having vitamin D. Oh, what is this vitamin D? One molecule, just we don't know. Most of the assays were not available those couple of decades back. Now, with the wider availability, we now know the prevalence and the importance of the vitamin D deficiency and insufficiency. Coming to the in front of the women power, the reproductive health, it supports the ovarian function and healthy follicular development. Crucial for the endometrial receptivity, vital for the successful implantation. Deficiency, which is less than 20, is associated 1.5 to 2 times higher risk of infertility in Indian. I think this is one of the important factors which should be included in the teaching. What is the metabolic health? The vitamin D is also important in glucose metabolism via VDR expression in the pancreatic beta cells, improves insulin sensitivity, reducing the risk of developing type 2 diabetes. So we don't know if it is a direct cause and effect, but we still know that there's enough scientific evidence to tell the vitamin D role in the glucose metabolism. Coming to the cardiovascular health, coming to the blood pressure, the sufficiency linked to 20 to 30% reduction in the hypertension risk. Prevents endothelial dysfunction, reduces the arterial stiffness. You can see the pleiotropic impact of the vitamin D as anti-inflammatory, vascular rigidity, smooth muscle proliferation, hypertension, endothelial function, lipid-lowering effect, and improve vascular tone. So on the left-hand side is the improve, and the right-hand side is the prevention of certain metabolic pathways. Now coming to the immune system, which is most talked about the action of the vitamin D, we know the vitamin D enhances the innate immune response against the pathogens, particularly vital in high burden regions like India for reducing the infection risk. Level more than 30 nanogram are linked to a 20 to 30% reduced risk of the breast and ovarian cancer. So this is sort of an epidemiological correlation. And vitamin D has been known to inhibit angiogenesis, which is very important, and promotes apoptosis in malignant cells. Neurological and the mental well-being, protective role against depression and multiple sclerosis in women. And it has been linked to the chronic fatigue, often misdiagnosed in the clinical practice. Now coming to the audience, which is mostly the gynecologists, reproductive obstetric care and high-risk pregnancy. We talked about today high-risk pregnancy. We talked about the recurrent pregnancy loss. We talked about the premature ovarian insufficiency. It has a dual requirement for the maternal and fetal development, required for the maternal health and the fetal skeletal development, and up to 96% of the pregnant Indian women are deficient. A public health crisis. That is why every gynecologist is happy to give vitamin D to any lady who comes to the as an antenatal visits. This is very important. And because the supplementation can reduce the risk of the preeclampsia by 40 to 50%. And the various mechanistic explanation is because of the different vitamin D deficiency causes decrease, impaired placentation, endothelial dysfunction, immune dysregulation, and again the RAS dysregulation. Any role in the reproduction? Well, because I talked to the endometrial receptivity is improved by the vitamin D and the implantation by the HOXA10 gene expression, which is a little bit improved. It modulates the inflammatory cytokines, reduces inflammation, increases the FSH sensitivity and progesterone production. Paracrine effects in reproductive tissues, deficiency disrupts ovulation and embryo quality. A big chunk of your practice, ladies, is the infertility. And the vitamin D deficiency reduces conception rate, even up to 75% fertility drop in animal models, and increases the miscarriages fourfold risk. Higher clinical pregnancy implantation rate in humans. That is why we do supplement vitamin D most of the patients who come for an antenatal visit. In the male, the vitamin D deficiency has been shown to reduce the sperm motility, progressive motility, and the normal morphology because it impacts the semen quality via the vitamin D receptor in the testes and the sperm. Sperm also is having vitamin D receptors. And the supplementation may improve parameters which can restore the fertility. Not any role in the preconception as a fertility support to improve the egg quality, for increasing the endometrial receptivity, and deficiency has been linked to the decreased fertility capacity in animal models, so we can translate the same thing to the human beings. ART, vitamin D deficiency and insufficiency are common in women undergoing ART as IVF. That is why any patient going for ART should be checked for the vitamin D levels. And there are improved charts. Some of the meta-analyses have shown that women who are vitamin D replete are more likely to achieve a clinical pregnancy than those who are deficient or insufficient. Now, what are the ultimate outcome in the live birth rate? Because the most important measure of ART success is the live birth rate. And it's a positive association. One systemic review and the meta-analysis found a statistically significant association with replete women having 1.33 times higher odd ratio of live birth. And the vitamin D deficiency is a common modifiable condition that could be easily and cost-effectively treated in women planning fertility treatment. Well, a most important topic for the endocrinologist, what we teach, the gestational diabetes mellitus. And we know the deficiency increases the risk of GDM. Early pregnancy deficiency predicts GDM, the South Indian cohorts. There are some good journal articles from the India also to show about the impact on the fertility. Fetal growth. Low maternal vitamin D is a predictor of the low birth weight and small for gestational age, and adequate levels ensures adequate calcium and transfer across the placenta. Preterm birth and spontaneous abortion are associated. The optimum middle reduced risk of preterm if you have optimum vitamin D level in your body, and there is a possible role in reducing rates of spontaneous abortion via immune modulation at the decidua. Now, the vitamin D receptor polymorphism in pregnancy. There's a lot of studies from India too that the APA1 and FOCI polymorphisms are linked to the higher GDM risk in North Indian women, which has been proved. And that explains increased vulnerability to vitamin D deficiency, complications like metabolic issues leading to GDM, and similar association in other populations like Iranian women with APA1 and TAQI gene polymorphism. Maternal fetal bone health depends upon the vitamin D adequacy, and the severe deficiency lead to neonatal rickets and the impaired enamel formation, which is absolutely known to all of us. As endocrinology, we always see neonatal rickets in patients who are low socioeconomic status where they don't get the adequate sources of vitamin D. Low levels of vitamin D, I don't know what is the cause and effect. This primary cesarean sections are increased. A relationship between when they saw the various records due to the impaired muscle function, increased risk of the pelvic muscle dysfunction. Postpartum health, again we come to the postpartum. There's high vitamin D during lactation, and you have to take at least 2,000 international units per day. and the deficient mother produce vitamin D poor breast milk, risking the infant health. What are the screening protocols in pregnancy? You all of you know very well ACOG guidelines, FOXY guidelines, early screening for high-risk groups, including those with limited sun exposure and where the body mass index is more than 30, and you have to achieve sufficiency early in the first trimester. Now coming to the menopause and the fracture cliff, the most dreaded complication in the menopause because of the postmenopausal osteoporosis, because the postmenopausal estrogen decline accelerates the bone loss, and deficiency in this group is as high as 94% in India. Sarcopenia and the fall prevention. Vitamin D improves muscle strength and balance in the elderly. We can prevent the risk of falls as the primary cause of the hip fractures. Some of the emerging evidence suggests that vitamin D may inhibit the growth of the uterine fibroids, endometriosis, and inflammation because of the anti-inflammatory effects of the vitamin D may alleviate the symptoms of the pelvic pain in endometriosis. Menopausal vasomotor symptoms, low levels of vitamin D may exacerbate the severity of hot flushes and the night sweats. The obesity, we are all talking about obesity. Obesity has become a national agenda nowadays. And you can see in last 1 month, there have been at least 50 podcasts just focusing on the obesity treatment. Vitamin D is sequestered in the adipose tissue, making it less available in the bloodstream. Obese women require 2 to 3 higher doses for the depletion. Urinary incontinence is a very common problem with most of the gynecologists come across, and there have been some observational studies, postmenopausal studies, mechanistic research, where they have shown that vitamin D receptors in the pelvic floor muscles suggest a role of vitamin D in maintaining continence. Cardiovascular risk in postmenopause, 1.5 times, and again the deficiency may lead to the CVD events more, including stroke and heart failure in older women. Chronic fatigue syndrome is a term we give the diagnosis, many of the patients where we don't know what to do. Many women presenting with vague pelvic pain and fatigue are severely vitamin D deficient. And lastly, but not the least, where we are here, Walter Bushnell has revolutionized the technology of the vitamin D nanotechnology because of the various reasons I'm going to tell you right now. Because vitamin D innately is a fat soluble, leading to poor bioavailability. Traditional oil-based preparation require high lipase presence and co-ingestion with fatty meals. Conventional tablets which were available earlier in a capsule often leads to leakage of vitamin D molecules from the fat particles during digestion. High variability in cholecalciferol content exists across commercial Indian preparation. A very beautiful study from the AIMS, we have taken the different preparation of the granule preparation, all of them gave a different efficacy because of the different content exists in each formulation. So we have a vitamin D limitation of the traditional formulation, granules, tablets, and capsules, the soft gel capsule. But if you see even the conventional nanotechnology syrup formulation, when subject to the high dilution by GIT fluid, results in breakdown, decrease in the number of micelles. The latest technology advancement and introduction to nano carrier and trapped vitamin D3. I think you are here very good vitamin D, battery with D3. And this is having 4 layers, hydrophilic layer, enzyme resistant steric barrier, pH resistant electrostatic barrier, lipid nanocarrier, and vitamin D molecule at the core of the whole thing. So this is called equal nanotechnology, provides stable nanoparticle structure. And imagine the droplet size is less than 150 nano, significantly smaller than the conventional emulsion, which is less than 200. So it ensures the up to 90% absorption, protects vitamin D from the digestive enzymes and pH fluctuation in the GIT, direct delivery to the intestinal absorption sites, and ensures rapid and efficient uptake. So, congratulations Walter Bushnell for having given us the Motivate D3 as the latest technology, and we can use this effectively in our day-to-day clinical practice. And There are studies where they have shown the 4 times raise in the serum levels in 8 weeks. The evidence, optimal vitamin D level more than 40 nanogram in just 8 weeks. There's no need to give shots, which most of the people are very fancy. As endocrinologists, we never prescribe the injectable 6 lakhs units, and that is only recommended when the patient is having malabsorption. Otherwise, there is no role. People think we give a 6 lakh shot of intramuscular of vitamin D, it will raise the vitamin D level quickly. No, that is a misconception. So I never prescribe the shot of vitamin D. I always prefer to give the oral formulation, which is adequate enough to give the adequate level of vitamin D over next 6 to 8 weeks. So this was an Indian study which evaluated the equal nanotechnology vitamin D syrup versus conventional nano syrup in vitamin D deficient patient. And you can see the cause 5.5 times rise in vitamin D levels from the baseline, where the conventional nanotech vitamin D syrup causes only 2.8 times in 6 weeks time. My dear friend R.K. Marwa has also done many other studies in the older formulation of the nanotechnology vitamin D. Now there is just a comparison between the conventional and the nano carrier and trapped vitamin D3. See the droplet size, bioavailability high, meal dependent, independent of the fat intake, absorption time is rapid, and levels of vitamin D is 4 times as compared to 2-3 times in the baseline. Simplified dosing, initial corrections, 60,000 units once in a week, but not more than 8 to 12 weeks. And the maintenance is just 60,000 per month. And most of the prescription I see loaded with the vitamin D. So we should not do that. Routine prevention, 2,000 units per day, which I am very fancy, just giving 2,000 per day. And monthly maintenance dosage throughout the pregnancy is the order of the day. High risk dosing, obese patient may require 2 to 3 times higher doses, and nano carrier technology is particularly beneficial here due to bypass of the traditional fat solubility. American Association of Clinical Endocrinologists, vitamin D in women's health, all women, PCOS, infertility, IVF, pregnancy, postmenopause, obese, and elderly women. So to conclude my talk, vitamin D is everywhere, with every disease. Name any disease, there is a role of vitamin D. And let's see what take-home message you should carry. Because of the pleiotropic dominance, vitamin D is no longer just a bone vitamin. It is a systemic prohormone whose receptor dictates the health of ovary, endometrium, and the placenta. Achieving sufficiency is a prerequisite for successful IVF, management of the PCOS-related metabolic dysfunction, and reduction of uterine fibroid growth. Adequate levels are the first line of defense against the great obstetric syndrome, the preeclampsia, JDM, and preterm birth. The lifespan length from adolescent peak bone mass to preventing the postmenopausal fracture cliff, vitamin D is a constant threat in the woman's wellness. The problem, the absorption ceiling, has been already sorted out by the latest technology, nano carrier and trapped, with a good bioavailability, rapid absorption, and a good amount of vitamin D level. Clinical advantage, predictability, simplified treatment protocols. And to end my talk, you have been listening very quietly. I think it is already 9:70, you might be feeling hungry. In every stage of the woman's life, from the first heartbeat in the womb to the grace of the golden years, vitamin D is not merely a supplement, it is a silent architect of our vitality. By optimizing this pro-hormone today, we are not just treating a deficiency, we are securing the health of next generation. Let me hope from today onward, each and every woman sitting in this audience will start taking vitamin D as not as a tonic or as a vitamin, but as a woman's health from birth to the tomb, throughout all the years from the birth to the end of life after the menopause. Thank you very much for your kind listening. And it was my pleasure to come for the first time in this forum as an endocrinologist to deliver a talk in front of the beautiful women. So I am blessed today. Thank you very much.
Hello. Thank you, Professor Subhash Wangnoo, for a wonderful talk. And first and foremost, I would like to thank the Barlia family. We are a part of the family, I feel, so many years we have come here, all of us here. And like it is a very like annual scientific ritual for us, We would be very uncomfortable if we don't come here and meet and interact. And I would also like to thank Dr. Professor J.B. Sharma. He's been a fantastic beacon of knowledge and inspiration for all of us. And thank you for, please give him a big hand. And of course, our speaker is a very renowned and eminent figure. And I would like to say that vitamin D is very important. Believe in actually multiple micronutrient supplementation also for everyone. If I was, I think one day, today it's been actually a very important day for all of us because our Prime Minister, Mr. Modi ji, has launched the HPV vaccination and he's launched nearly 1 crore vaccines. I don't think anyone in the world has done such a thing before, and we must thank him and our beloved Health Minister Nada ji for doing this fantastic job. He launched it in Kota, and I have been given to understand that 2 or 3 crore additional vaccines will be also released. Who does that? Our country is a fantastic country. Imagine taking care of 1.4 billion people and their health, and it's an amazing job that our government is doing. And also coming to this, actually every one of us should take vitamin D, but targeted screening. Maybe one day Modi ji will also make vitamin D testing free for everyone, so that those who are deficient.
In India, we don't require any testing. Give vitamin to everyone.
So,
Everybody is deficient.
now tell me one thing, that if we give without testing,
There's
how
no
many
harm.
doses we give?
Same protocol. You start with every patient for 2 to 3 months weekly, and then followed by monthly as a primitive dosage.
Okay, so
of
you don't need to
2000 per
test. But
day.
what
No.
about hypervitaminosis, the fear?
With this dose, you will never get the hypervitaminosis D
Okay.
toxicity.
So we don't need to test. We just need to give it, take it for all of us. Great. Thank you very much again.
Good evening. First of all, thank you, Walter Bushner team, for organizing such informative sessions every year, and they provide a full bout of information and knowledge at least for 1 year. So we are thankful to you. Thank you, sir. Regarding vitamin D, see, there are two aspects now. Vitamin D has been associated or has been implicated with all the disease processes nowadays. But how far evidences are there to find the causal effect relationship? That is, one has to be carefully look into and then see how much it will be going to affect the health of the particular individual. Number two is we all know in our country osteopenia is a very major problem, and we have to take care of osteopenia, and by correcting the homeostasis of calcium as well as vitamin D, a lot of condition can be taken care, and it obviously improve the health of the person or as a woman, and it also improves the pregnancy outcome. So these are the things which have been coming up in the literature as evidence, and more and more evidences are coming up where the association are found to be very strong. So we have to be very careful about our process of bone health and calcium homeostasis outside the pregnancy as well as during pregnancy also. Thank you very much.
I think Dr. Professor Wangnoo has done a very good job of highlighting the role of vitamin D. I think we all know it, and we are a vitamin D deficient nation. We know that also. With rising levels of air pollution, and the UV rays are blocked to reach our skin, and that is why we, in our country, I think we really need to address this problem of vitamin D deficiency. And because it needs a very, a 3 monthly or a 4 monthly injection is not going to help. So this nanotechnology that has brought, in raising the vitamin D levels to 4 times in 8 weeks. I think it is a fantastic thing. It's really a boon for everybody, because I also see in my practice that vitamin D is very low. Very often we come across levels as low as 5, 6. And the patient just has very vague symptoms, chronic fatigue. She doesn't know where it is coming from. And we, first of all, I used to think it is a protein deficiency, but then when we started getting it checked, we realized that it is vitamin D deficiency, and when we replenish it, the patients start improving. So this vitamin is very important for women, right from her when she's an adolescent girl to her young days, pregnancy, and then even in menopause. So I think I really congratulate Walter Bushnell for coming up with this very interesting molecule, which gives you a better bioavailability, because bioavailability is a big problem with other brands. It requires fat absorption, otherwise the conventional brand, and it requires magnesium as well. But now with this nanotechnology, I think we are going to achieve a much higher levels in a much shorter time without going for repeated tests. So it's a very good molecule.
Thank you, Walter Bushnell and family, for inviting. It's always a pleasure to be amongst the august audience. And today's topic, a very important topic, something we all need to look into our patients when we see them day to day. We check their hemoglobin, we check their thyroid, but do we really check their vitamin D? It's still not in routine guidelines internationally, but it's important, and the talk has highlighted that. Cases of low AMH, male infertility, polycystic women, we are doing PRP, stem cells, TESSA, micro-TESSA, ovarian drilling, but perhaps supplementing with this simple molecule will help them immensely, much more than many other treatment, much expensive treatment that is going to this patient. But of course, a word of caution, and I completely agree with Professor Ashok Kumar, who has highlighted that most of these studies are associations. There are few randomized controlled trials, not very much in the subcontinent, and all of us here should take it as our responsibility to prove it with much more stronger literature. But I'm sure vitamin D is here to stay, not only for young children, for young ladies, and also for the perimenopausal and menopausal women. Thank you very much.
Thank you, sir, since I'm the last one. So I'll just very quickly, wrap up. And thank you, ma'am. If you remember 22 years back when I came to Delhi, then with Mr. C.M. Chabra, I think you were one of the first ones I met and made some modules for Walter Bushnell. And I'm so impressed by seeing such keen, delegates sitting and hearing so patiently. I would say that number one, to begin with, we must estimate vitamin D levels. We need more robust studies to know what are the cutoffs in Indian population in different segments, because we are still following the Caucasian world. Without estimation, I think incessant prescriptions should not be given, because there is a positive side, which even, when this topic came in, I thought, what is the pleiotropic part of vitamin D? And then I realized, oh my, from top to bottom, everything has a receptor in the body. Yes, it works well. We need to identify who needs a higher dose, who needs a lower maintenance dose. And not to forget, I think lifestyle management and weight bearing exercises is something which should not be forgotten at all. So it's supplement, it's lifestyle and weight bearing exercises which need to go hand in hand. Thank you so much, Walter Bushnell, for coming up with a wonderful molecule. I'm sure in ages we are going to see wonderful effects, and we would love to do some studies, especially in the male infertility, looking at two arms, one getting only antioxidants and one getting antioxidants with vitamin D. And if that shows a very, very positive effect, then we know for sure that vitamin D is here to work for long. So thank you so much to make us a part of this wonderful session.
I think before the closing session, I just want to make a very important statement from this podium.
Before that, ask you one thing so that you can add
Yeah.
to it. With all this new weight loss medicines, Do you think we need to supplement vitamin D in those as well?
Yes, it's a very important topic because all the newer weight loss agents, the GLP-1 receptor agonists, apart from the fat loss, they also cause sarcopenia, means the muscle mass loss. And vitamin D is important for the muscle strength. That is why we tell our patient whenever you are on the treatment, take high protein diet, do resistance exercises, muscle building exercises, so that you don't get sarcopenia and they'll be fall because of the sarcopenia. You will land up in the fractures. So we supplement all of them with the vitamin D and calcium. Why I wanted to make important statement because I'm very happy today my Guruji and teachers are on the audience. Professor L.K. Pandey and Sulekha Pandey, they are sleeping right now. Yes, sir. And I must pay my tribute and respect to them. They had taught me from the Banaras and the University, the very famous gynecologists. And as I'm lucky to have, they are here and listening to my talk. Thank you very much.
With that, we thank the erudite panel for a very engaging deliberation. I request Mr. Nishant Barlia to kindly present mementos to the distinguished panel. We begin with Dr. Subhash Wangnoo. Dr. Rishikesh Pai. Dr. Ashok Kumar. Dr. Anshu Jindal. Dr. Kaveri Banerjee. And Dr. Shweta Mittal Gupta. Let's have a group photograph. We're having a group photograph. I request Dr. Poddar, President DMA, also to join us. Thank you so much once again. It's a great privilege and pleasure to express our gratitude to all the dignitaries and delegates for their gracious presence here this evening and for making this program a success. And special thanks to Madam Sushma Paul Barlia, Mr. Nishant Barlia, and Dr. Neha Barlia. And our heartfelt appreciation also goes to all the speakers and chairpersons for sharing their expertise. So before we conclude, may I remind you all that tomorrow we will be hosting here at the same venue at 10 a.m. in the morning, 12th edition of IOG Dr. Stya Paul Awards and Oration Lecture by Dr. Deirdre Lyle. So please join us tomorrow morning as well. Thank you. Enjoy the dinner. Have a very good night. Thank you.